Dr. Stephen Ayisi is my name. I'm the head of the National AIDS and STI Control Program of the Ghana Health Service. Since the first case of HIV was identified in 1986, we have been monitoring the epidemic trends from 1992 through annual sentinel surveys among pregnant women, and we use that data as a primary data to be able to estimate for the whole country. Since we found the first case in 1986, as at the end of 2023, there are an estimated 334,095 persons living with HIV. These are people out of the 32 million Ghanaians or so who are living with HIV in Ghana. Of that percentage, about 7% are children, and almost 60%, let's say 70% are female. So in Ghana, HIV has a gender face, a female gender face majority, and it makes sense. Women are more vulnerable compared to men when it comes to HIV. Let me state that of this estimated population of people living with HIV, there are different subpopulations with different prevalence. The general population prevalence is 1.53. Prevalence amongst pregnant women who entered antenatal is 1.6. And this was 2% the previous year. It's dropped to 1.6. Prevalence among female sex workers is 4.6. But before I go to female sex workers, when you take people who are in prisons, incarcerated situations, their prevalence is 2.3. And people who inject drugs, it's a high risk, it's 2.5%. The female sex workers, because of multiple partnerships, the commercial sex is 4.6. Then men who have sex with men have a prevalence of 26%. And people who are referred to as transgender women have a prevalence of 48%. It means that if you take 100, almost 50 of them are HIV positive. We have noticed a declining trend overall in deaths due to antiretroviral therapy. Since we found the first case, we put the first person on treatment in 2003, so we're doing our 20 years and more of antiretroviral therapy. Because of that, the rate at which people were dying has declined over time as we increase the number of treatment. Whichever put about 300,000 people on treatment, but some of them have died. As we speak now, we're doing almost 200,000 currently on treatment. As a country, we've agreed that we've committed to the aspirational WHO UN's targets of 95, 95, 95. And the first 95 is that we should be able to identify 95% of the estimated 334,000 I talked about. As of December 2023, we had identified 65%. The second 95 says that of this number identified, you should put 95% on treatment, and we had done 69%. And the third is that of the second 95, you have to make sure that they are on treatment, they have viral suppression, they have to have access to viral load testing. We have done 89% of that. So as far as the 95 is concerned, we are 65, 89, 65, 69, and 89. It is important to indicate that whereas there are reductions in certain areas, there are challenges in some areas. So, for instance, new infections as at the end of December 2023 was about approximately 17,700, and deaths were 12,400. These were declines from the previous year. We had plateaued around 20,000 for new infections, a little over that. It is now dropping. When it comes to the deaths also, we're doing around 15,000. And 16,000 now is dropping. All these have been because of the progress we've made as a national AIDS control program, leading the implementation. We have rolled out several interventions. our mandate is to deliver the package of services to prevent new infections. And in that context, we have to provide information, education, communication, behavior change communications, promote condoms, manage STIs very timely, because anybody who has an STI has a higher risk of HIV. At the last count, the HIV prevalence among STI clients was 8%. It used to be like 12%. And so managing STI is a preventive strategy, early detection and treatment. So that's one of the ways that we use it to prevent the infection, apart from condom promotion. Now we've introduced what we call post-exposure prophylaxis and pre-exposure prophylaxis. When somebody is exposed to potentially infectious substance, blood, and has risk of HIV, we do post-exposure prophylaxis. However, we've introduced pre-exposure prophylaxis for key population, men who have sex with men, who have a higher risk, I said 26% prevalence, so that before they have an encounter with somebody, you take the PrEP, and then so that you don't transmit or get it from another person. So that's also a prevention strategy. The second mandate is to deliver a package of services for comprehensive treatment, care and support, and that is highly active antiretroviral therapy. We've been doing that for 21 years. And we also talk about management of all opportunistic infections as part of the treatment, management of comorbidities, people who have tuberculosis. HIV prevalence among TB clients, 14% is high. And because of the antiretroviral therapy now, survival of TB clients who are HIV is better than the general population of TB clients because of treatment. So that is one of the very impactful, interventions that has led to people surviving and in good health, and we have an aging cohort of people on treatment. The third intervention is to provide technical assistance to all stakeholders, and that we do effectively, including the media, everybody, building capacity and all that, and generating the information to guide the national response is the fourth mandate. So all these are interventions that we roll out. When it comes to our, in summary, cross-cutting broad comprehensive services, prevention, education, treatment, PMTC is prevention of mother-to-child transmission services. So HIV testing services, treatment services, and supportive psychosocial care to people living with HIV. Our progress to date has not been without challenges. We've gone through a lot of difficulty. In the past, we didn't have enough resources. We are a lower middle income country. So even treatment, you needed to, manage it, use a criteria to be able to initiate people on medication, CD4 count, but because we were resource limited. But by the grace of God, with the continuous support of stakeholders and government, now we do what we call test and treat. Everybody who is positive is eligible for treatment. You don't have to wait as we used to do in the past. Everybody must be started with treatment immediately the moment you are, HIV positive. And that means that the commodities are now available to be able to support that initiative. We have also made a lot of progress in terms of testing. We're doing what we call the family-based index testing people who are very close to people who are already positive. And that has made a big difference. Index testing leads us to people who are at higher risk. And the newest thing that we've introduced is HIV self-test, where now you don't need to come to the health facility to test. With a self-test kit, you can read the instructions and then you test. And then if you are reactive, you go to the closest hospital to confirm before you are put on medication. These are all steps forward to make sure that we improve access of people. We've also scaled up the number of testing sites, over 6,000 in the whole country. We are doing about 4,000 to 6,000 PMTC sites. Antiretroviral therapy sites around 735,000, but we want to decentralize to all the sites so that people can easily get antiretroviral therapy wherever they are in our country. The reason why we've not reached everywhere is some of it is human resource limitations, issues of infrastructure limitations, commodity to the last mile. If you start anybody on treatment, you need to support the person with laboratory monitoring. It's not available everywhere. Everywhere have good labs. So we are working through the health system, existing health system, and therefore we are limited by the development or the status of the health system. So these are some of the challenges. Limited funding to cover all areas. Human resource attrition is a challenge because we're training people and they are leaving the country, health workers, nurses. But this is how we've tried to address the challenge of human resource. We've tried to go around it by introducing what we call the task sharing. So in the past, it's only doctors who start treatment, initiate. It's clinician-led. Nurses were not prescribing or giving antiretroviral therapy. But we have changed that. Now with task sharing guidelines or task shifting guidelines, midwives can give treatment. We are even doing now community distribution of antiretroviral therapy. We are piloting some right now, where very soon people who are stable, once you have been registered, you take your medication for starters in the health facility. Subsequent pickups, you take it in a community location convenient to yourself. All this is to improve access, to reduce long waiting times and all that. We've introduced what we call differentiated service delivery. When people used to come one day clinic, now the clinic days are spread throughout the week and we don't take huge numbers. Now we are creating one-stop shop areas where people can access medication. They don't always have to go to only one source for treatment. So now when you come, you are stable, we give you 6 months. Can you imagine the past? You will not get 6 months medication. So 3 to 6 months, we give you, you are away, you are fine. So these are things that we have done to overcome some of our training. HR challenges, some of the way we want to overcome going forward is online training. We are launching e-learning platforms so the health workers can be trained everywhere. They don't need to come together. It's more expensive to bring them to a hotel. So we are doing that so that even if people leave, every time we can train them. We're linking it to continuous professional development so that they will use it to renew their PIN. Then the motivation is very high. We have also come very far in now bringing in civil society. In the past, the program was very limited to the public sector. But now we've brought in private sector. Private sector, because of sometimes profit issues, programmatic issues are free. So it's not easy. And the civil society where work was unfunded, in this particular cycle, we have engaged a lot of civil society groups, quite a number, and they are involved in test kit distribution, condom promotion, and they are playing an important role in linking people to treatment. So we have case managers, we have community adolescent treatment supporters, we have mental mothers who support pregnant women who are positive on treatment to adhere to their medication. We've had challenges such as commodity available and then shortages. Sometimes it's because of clearing from the port, delays in clearance. But recently we have been able to overcome that challenge. We hope that going forward we'll be able to do more. Now it's very clear that our development partners may be transitioning out, even though they've supported us. And there's a greater push for government to pay every part to increase domestic support. And so we've developed what we call a sustainability plan. We've done an investment case which is supposed to guide us to know that, look, if we inject this amount of money, it will lead us to epidemic control, but that money must come from somewhere. So we started the advocacy and discussion with political leadership to ensure that the HIV needs are actually budgeted for comprehensively in our national budget. They are taken care of, so that whatever our development partners bring will just be what we call complementary funding. Already what government is doing is huge, because government is taking care of infrastructure, taking care of human resource, training, salaries, and all that. Government is also providing laboratory infrastructure, equipment. So all these are already being done, but now it looks like all areas must be covered. So there are discussions with health insurance to cover some aspect of treatment and all that. So clearly we've made progress, but there have been challenges. Stigma was very high in the past. but we have now overcome stigma. A recent survey showed that there's still stigma within health facility and in the community. There is what we call also internal stigma and external stigma, which means that the people living with HIV themselves stigmatize themselves. We've gone away from the time where people deny people of jobs because of HIV, but that is incipient. We still have people who are subtly stigmatizing people. People used to be thrown out of homes because they were HIV. Now those things we're not hearing again. Pastors used to deny people marriage. Now we don't want to hear that. We are not hearing that again. We have discordant couples, one positive, one negative, who are married, their children are negative. Because of the elimination of mother-to-child transmission services, the confidence has increased, people are motivated, and so stigma is reduced significantly. Last 2 weeks, we had a walk, and people living with HIV were part of it. They were confident to show their faces. It means that they've overcome self-stigma, and that means that we are making progress. But if we need to achieve our targets, the 95-95 target by next year, we need to get rid of stigma completely, because there are still some people who are uncomfortable. And I understand that, because if you are in a community or population where only 2% of people are HIV, 98% are negative, they will be looking down on the rest of the 2%. But we need to do everything to make sure that we remove every form of stigma, so that people will confidently access services, people will feel free to interact with others, they will talk about HIV, talk about sex, and then be able to preach prevention. One of the challenges we face is that we become victims of our own success. And in the past, we didn't, there was fear and people were falling sick. But today you don't see that. So the youth, for instance, don't think HIV is real. And the advocacy and the noise about HIV has gone down significantly. The media houses, we're not giving them money again to do it. They have to volunteer as part of corporate social responsibility to bring back the message, because transmission is occurring. I told you, between January to September this year, the National AIDS Control Program screened about 1.3 million people, and 35,000 were positive, which means that new infections are occurring. And therefore, we still have to continue the message. Before we achieve epidemic control in 2030, we ought to be more creative, send a message to social media, send it to different platforms and portals beyond the traditional training in classroom or maybe in a hotel or anywhere. Beyond the traditional media houses, we need to make space and send a message every day, increase top of the mind awareness. So this year, to be able to do something innovative, we launched the antiretroviral therapy at 20, and we celebrated it with a number of events, media launches. We've done various activities with the youth in secondary schools, and we've we had a research agenda, we had the AIDS walk. There ought to be increased advocacy to be able to put the message out there, for everybody to know. Fortunately, Ghana won the bid to host ICASA, International Conference of AIDS and STI in Africa. Next year, 2025, we'll be hosting. And yesterday, we had a meeting of the first steering committee, international steering committee. It's going to serve as another opportunity to show up the message, to advocate for resources, to be able to increase the messaging around HIV, bringing the role of Africa here, and will strengthen our health system, will contribute to the national response, and I believe that to a very large extent, it's going to help us overcome some of the challenges, and we have a bright future ahead of us. I think that we've come far. We've been able to reduce the burden of HIV. The mortality, in other words, the deaths and the illnesses associated with HIV is reducing, but there's still ignorance, there's still lack of knowledge. We need to go back to the basics. ABCD of HIV prevention should be promoted. We ought to go back to let people know that though HIV is no more scary, like it's a death sentence and all that, it's still, transmission is still occurring, and people are dying unknowingly because they have not taken the necessary steps. In this day and age, no mother should give HIV to a baby because there is treatment. In this day and age, nobody should die from HIV-related conditions because there's treatment. People who are adhering have been on medication for 20 years and more. Some are 70 years and more, they are well. As long as you adhere to your medication, you will exit anyway. It's inevitable for all of us, but it must not be because of HIV. Our vision and our goal is to be able to end the epidemic by 2030. As a country, we can do it. If you join hands with us, if you partner us, if you do your bit, give us the platform. Also go out there to be an ambassador for HIV. Reduce the stigma, help to reduce the new infections, and help to limit the deaths associated with HIV. On this occasion of World AIDS Day celebration, it's very important that we all walk the right path. The National AIDS Control Program is taking the right steps, and it's because we believe that when you respect people and when people are safe, they have confidence to choose the kind of care they want. And when they get the right kind of care, quality care, they are empowered to live positive lives. And when they live positive lives, we all create the right environment to ensure that this country becomes a country with a generation that is free of AIDS in the shortest possible time. Thank you very much for your audience.